Hello, everyone. My name is Victoria Kulikova. I'm an assistant professor of Chair of Faculty Therapy #1. Today, I'm going to speak to you about aortic valve disorders and tricuspid valve disorders. So, the aortic valve consists of three half-moon-shaped pocket-like cusps. When the aortic valve is closed, the cusps are perfectly aligned and separate the left ventricle from the aorta. In systole, during the period when the left ventricle contracts and pumps the blood, the aortic valve opens widely and blood flows freely from the left ventricle to the aorta. In diastole, when the left ventricle then relaxes, the aortic valve closes completely so that the blood remains in the aorta. Here are normal anatomy of the aortic valve and aortic root on the left picture. Root extends from the basal attachments of the aortic valve leaflets, it's a green line on the picture, to the sinotubular junction, it's a blue line on the picture. The aortic valve have three cusps: non-coronary, right coronary, and left coronary. According to three cusps, there are three sinuses or sinuses of Valsalva. The aortic sinuses have no effective on valve competence, but are important in reducing mechanical stress on the aortic cusps during the cardiac cycles by creating eddies and currents between the cusps and the sinus walls that you can see on the right picture. The next important function of sinuses is to provide space behind the open aortic leaflets so that the leaflets do not occlude the coronary artery offices. So now let me speak about aortic valve stenosis. A few words about epidemiology. In the European population, aortic valve stenosis is the most common valve abnormality, about 34% in the overall group and 47% in surgical subgroup. The prevalence of aortic stenosis increases with age and varied from less than 1% in ages under 60 to about 10% at ages over 80. So the most common causes of the aortic stenosis are bicuspid aortic valve. It's more than 45% of patients with aortic stenosis under 65 years. Calcification of the aortic valve, it's up to 82% of the patients, and rheumatic nature, up to 25%. Rare causes include metabolic diseases, for example, Fabry disease, systemic diseases, etc. We also have to mention non-valvular left ventricle outflow obstruction due to supravalvular reasons. For example, it's Williams syndrome, and subvalvular reasons, for example, hypertrophic cardiomyopathy. So what happened in heart hemodynamic due to aortic stenosis? Actually, there can be no abnormalities in mild aortic stenosis over a prolonged period. Further, normal cardiac output is maintained at the cost of increasing pressure gradient across the aortic valve. Chronic pressure overload results to concentric left ventricle hypertrophy and diastolic dysfunction of left ventricle that leads to left atrium or mitral valve damage. So we face with left atrium enlargement and atrial fibrillation. Then the damage in left atrials leads to raising pressure in pulmonary venas and capillaries and pulmonary congestion. It results in pulmonary hypertension and tricuspid valve damage, which finally leads to right ventricle dysfunction and enlargement. Mild and moderate stenosis is usually asymptomatic. It's very important. Severe aortic stenosis include left-sided heart failure signs such as dyspnea or syncope, episodes of acute pulmonary edema, angina due to left ventricle hypertrophy, and a lack of coronary perfusion, and sudden cardiac death due to arrhythmias. So now one of the most important points in aortic stenosis diagnostic is cardiac auscultation. The typical murmur of aortic stenosis in a mid-systolic ejection murmur heard best in the right upper sternal border radiating to the neck and carotid arteries. Please hear the normal heart sounds and aortic stenosis murmur. So it's a normal. So, echocardiography with Doppler is the main instrumental investigation of valvular disorders. On the picture above, you can see scheme of the ultrasound valve. On the picture above, you can see a scheme of ultrasound and the heart structure's anatomy. We can evaluate aortic valve area, severity of stenosis, so it's velocity gradient associated with aortic regurgitation, hypertrophied left ventricle. Next, you can see real pictures of normal aortic valve, it's on the left, and aortic stenosis on the right. ACG. So ACG can show us left ventricle hypertrophy and left bundle branch block. Here you can see ST segment depression due to huge left ventricle hypertrophy. Chest X-ray can help us to evaluate left ventricle enlargement. It's a red arrow, and dilated ascending aorta sometimes. It's a white arrow. Indications for coronary angiography is the same for all valvular disorders. We need it before all valve surgery and in case of evaluation of secondary mitral regurgitation. Additional to aortic valve replacement, coronary artery bypass grafting or CABG is reasonable if stenosis more than 70%. There are mild, moderate, and severe aortic stenosis grades. The main echo parameters are on the slide. we evaluate not only aortic valve area. It's very important to find out peak velocity through the valve and mean gradient, or the difference in pressure on each side of the valve. So what's the indications for intervention? If it's mild aortic stenosis, there is no indication for surgery. Repeat echocardiography in 6 months. If it's moderate aortic stenosis, the indications for surgery are symptomatic aortic stenosis, left ventricle ejection fraction less than 50%, and undergoing CABG, or surgery of the ascending aorta or of another valve. If it's severe aortic stenosis, what we have to do? So now about severe aortic stenosis. So if there is no symptoms and left ventricle ejection fraction more than 50%, and the patient has a high surgical risk, re-evaluate him in 6 months. If it's symptomatic aortic stenosis or left ventricle ejection fraction less than 50%, it's indication for surgery. Now a few words about surgery. So in general, we can do surgical aortic valve replacement and transcatheter aortic valve implantation, or TAVI. If we suspect endocarditis or want to do CABG, or suggest another valve surgery, or the patient has aneurysm of ascending aorta, we choose surgical aortic valve replacement. In patients more than 65 years, or young women, or patients with contraindications for anticoagulation, we choose bioprosthesis. Otherwise, mechanical. TAVI is good for elderly patients with high surgical risk and previous CABG. Now, what about medical treatment? Actually, no medical therapy for aortic stenosis can improve outcome. The treatment goals are heart failure, arrhythmias, and thrombosis. Medical treatment should be carefully titrated to avoid hypertension. Mind about it when you use ACE inhibitors, diuretics, and beta blockers. Avoid using nifedipine. In patients after surgery, we use vitamin K antagonists. In mechanical prosthesis, low-dose aspirin for 3 months in bioprosthesis, and in TAVI, double antiplatelet therapy, first from 3 to 6 months, and single antiplatelet lifelong. Now let me speak about aortic regurgitation. Aortic regurgitation occurs in 14% in all valve abnormalities. The Framingham Heart Study, a prospective epidemiologic study, evaluated the prevalence of aortic regurgitation. The study revealed that the prevalence of aortic regurgitation is 13% in men and about 9% in women. The prevalence of aortic regurgitation varied with age and disease severity. As in aortic stenosis causes, the most common reasons are bicuspid aortic valve, rheumatic valve diseases, calcific valve disease. We also mention abnormalities of the aorta when that leads to aortic annular enlargement. So what happens in heart hemodynamic? Mild aortic stenosis not exposed to significant regurgitation, and patients are generally asymptomatic. Severe aortic regurgitation leads to left ventricle volume and pressure overload and left ventricle dilatation. Then it leads to volume overload of left atrial and left atrial dilatation. We can find out atrial fibrillation and signs of a left-sided heart failure. Thus, aortic regurgitation may be asymptomatic first time. Progressive ventricular dilatation leads to dyspnea, angina, and heart failure. On auscultation, the typical murmur of aortic regurgitation is a soft, early diastolic murmur heard best in the third intercostal space on the left, Erb's point. Please hear the normal heard sounds and aortic regurgitation murmur. So it's a normal, and now it's aortic regurgitation murmur. So another clinical features are low diastolic pressure, Demus's sign, Corrigan pulse, capillary pulsation, and systolic pulsation of liver and spleen. The most important instrumental investigation is echocardiography with Doppler. We also can do ACG to find out arrhythmias and other abnormalities. Chest X-ray indications for coronary angiography we discussed before. Using cardiac ultrasound, we can evaluate size of the aortic valve, root, aorta, left ventricle enlargement. Color Doppler helps us to find out jet width, regurgitation volume, and regurgitation fraction. Here you can see the scheme of the heart and regurgitant jet and a real picture of aortic regurgitation. There are mild, moderate, and severe aortic regurgitation grades. The main echo parameters are on the slide. We evaluate vena contracta width, regurgitation volume, and regurgitation fraction. Vena contracta is the point in the fluid stream where the diameter of the stream is the least, and fluid velocity is at its maximum. It is a place where the cross-section area is minimum. So you can see it on the picture. It's green lines on the picture. The wider vena contracta is the more severe aortic regurgitation is. What's indications for surgery of in aortic regurgitation? If it's severe aortic regurgitation with symptoms or with a left ventricle ejection fraction less than 50%, or left ventricle and diastolic diameter more than 7 centimeters, it's indications for surgery. Medical therapy of aortic regurgitation includes ACE inhibitors that may slow aortic root dilatation, low doses of beta blockers, indications for oral anticoagulants or antiplatelet drugs we discussed before. Now let me speak about tricuspid valve disorders. A few words about etiology. The most common tricuspid regurgitation in adults is secondary. The cause of secondary tricuspid regurgitation most likely in dilatation of the right atrium and right ventricle with dilatation of the tricuspid annulus, primary pulmonary disease. Primary tricuspid regurgitation happens in case of valve injury from implantable electronic devices, infective endocarditis, Epstein's anomaly, rheumatic valve diseases, etc. Tricuspid stenosis is a very uncommon valvular abnormality. It usually occurs with tricuspid regurgitation. Rheumatic etiology is the most common. What about clinical features? So no specific symptoms associated with mild or moderate tricuspid regurgitation alone. In severe grades, we can see right-sided heart failure, peripheral edema, ascites, hepatosplenomegaly, jugular veins. We can also find some symptoms of the underlying cause of tricuspid regurgitation, for example, pulmonary hypertension. Tricuspid stenosis symptoms depend upon the presence and severity of any associated mitral or aortic valve disease. The cardiac auscultation reveals the same sounds as the mitral valve disorders have. In case of regurgitation, we find out pansystolic murmur, in stenosis, mild diastolic murmur. Mind about the site of tricuspid valve auscultation. So ACG can evaluate right atrial enlargement. You can see huge P waves on the ACG. But the most useful instrumental investigation is, of course, ultrasound. There are mild, moderate, and severe tricuspid regurgitation grades. The main echo parameters are on the slide. Mild tricuspid regurgitation can be physiological valve regurgitation and have no indications for surgery. We choose surgery in moderate tricuspid regurgitation if it's secondary tricuspid regurgitation with annulus dilatation more than 4 centimeters, and we need for left-sided valve surgery. In general, all of severe tricuspid regurgitation, primary or secondary, are the indication for surgery. Indications for surgery in patients with tricuspid stenosis are severe tricuspid stenosis. So the main gradient through the tricuspid valve more than 5. Or severe tricuspid stenosis plus left-sided valve surgery. Mind that tricuspid regurgitation is often combined with mitral stenosis due to rheumatic disease and with tricuspid regurgitation. We can choose tricuspid valve repair or replacement, transcatheter tricuspid valve replacement, bioprotestic, mechanical protestic. Medical therapy includes diuretic, pulmonary hypertension therapy. So now, to sum it up, let me give you some key points of our today lecture. Mild and moderate valve disorders are usually asymptomatic. Tricuspid regurgitation usually secondary to right ventricle, right atrial dilatation. Tricuspid stenosis usually occurs with tricuspid regurgitation. Cardiac auscultation and echocardiography are the most important. Mind about indications for intervention and type of surgery, mechanical, bioprothesis, TAVI, transcatheter tricuspid valve replacement, etc. If the patient underwent mechanical valve replacement, he needs vitamin K antagonist, target INR from 2 and 5 to up to 3. Bioprothesis, aspirin for 3 months in case of aortic valve, vitamin K antagonist for 3 months if it's about tricuspid valve. TAVI, use double antiplatelet therapy from 3 to 6 months and single antiplatelet lifelong. So that's all for today about aortic valve and tricuspid valve disorders. Thank you for your attention.